So I'm going to speak about the work I do in Ireland, managing the Irish hip fracture database, and just tell you a little bit about the development of the audit and how it's progressing over the last few years. So just to put into perspective, we heard earlier on that Sigrun, they have about 250 to 300 hip fractures in Iceland. In Ireland, we have 3,700 hip fractures over the age of 60 every year. We've 16 hospitals that operate on hip fracture patients. And we know that there are going to be more and more hip fracture patients in the future unless we can prevent them. So we need to get our act together and look after people well when they come into our hospitals. We know hip fractures can be a devastating injury, so there's a really good rationale for looking at hip fracture patients as a group. I suppose part of the reason we are able to audit hip fractures so well is because it's a very clearly defined diagnosis. We have a very good evidence base now internationally for how we should care for these patients. We know that care is very costly, and many of these patients will end up requiring longer term care or rehabilitation or home supports. So if we're not looking after patients well, it's going to cost an awful lot more in the future. So back in 2012, the Irish hip fracture database went live. We had started talking in 2008 about setting up a national register, but it wasn't until 2012 that we started inputting data, and it's grown quite rapidly from there. We've had 5 national reports, over 14,000 cases collected, and we have developed our own Irish hip fracture standards of care from the international evidence. More recently, we've introduced a best practice tariff similar to the UK, and I'm going to tell you a little bit about that as the presentation goes on. Our 6 standards currently, the clinical standards, are broadly based on the UK Blue Book. Patients must be admitted to an orthopaedic ward within 4 hours. They must have their surgery within 48 hours, but we're looking at reducing that timing down to 36 hours now. They must be seen by a geriatrician. They must have a bone health assessment, a specialist falls assessment, and not develop a pressure ulcer. In our database, we only record grade 2 pressure ulcers and higher, and that's a bit different in some of the other hip fracture registers around the world. But just to be clear, for our own register, it's grade 2 or higher. What we've done last year is really, in an effort to try and support the hospitals to use their data themselves, is we've developed good guidance around what hospital governance should be about in terms of the clinical management of hip fractures. So who should be on their local governance committee? It should be multidisciplinary, it should be led clinically, and the types of things that they should talk about at their meetings. For example, every quarter we provide a very detailed quarterly report which shows how the hospital is performing against the standards of care, what that's looked like over a period of time, and give them the opportunity to reevaluate their service and make improvements. So it's not a stick to beat people with, oh, you're the worst or you're the best. It's actually just to allow hospitals to improve continuously, because there's always room for improvement. Another thing we've introduced last year, in Ireland we have a body called HIQA, the Health Information Quality Authority, and they set a lot of standards and guidance around different aspects of healthcare. And last year they published data quality standards for audits particularly. So we've adopted their data quality standards, and we are now measuring our national audit against these 5 key data quality standards. So moving on. We now have a really good idea of who our hip fracture population are, what they look like, where they come from, how many of them come from a nursing home, how many of them go back home again. In 2017, these are some of the key highlights from the report, but I'm actually going to be able to share with you a little preview of the 2018 results because we're nearly finished the analysis so far. But what you can see in 2017 was that only half of patients with a hip fracture were being seen by a geriatrician. Now that might sound absolutely terrible, but 2 years prior to that, we had virtually no patients being seen by a geriatrician. So there has been a big improvement Part of the reason for that was when we started out the hip fracture database, there was no such specialty as an orthogeriatrician in Ireland. But over the last number of years, we've actually managed to grow so that I think almost 85% of the services around Ireland now have an orthogeriatrician coming routinely to the ward to see our hip fracture patients. So there's been great progress. What you can see is obviously the secondary prevention still needs some work. Only half of patients were getting a specialist falls assessment, and 3/4 of patients almost having their surgery within 48 hours. So lots of progress, but lots more work to do. Within the database itself, obviously we measure key clinical standards, but we collect lots of really good information that's very valuable to lots of specialties. So this is just an example. We collect obviously the different fracture types and types of fixation, and we're currently working at building a more detailed database of implants so that the orthopedic surgeons can look at the cost effectiveness, they can look at the refracture rates, the complications associated with different implants. So that's something that we're really looking at the moment, which is it's great, it's very interesting. And what we did last year was we looked at the group of patients that go directly home from hospital to see what we could learn from them. So we could see that just over 1 in 5 patients were going from hospital directly back home, and we wanted to figure out what's so special about that group, because we'd like more patients to go directly home. And what we found was that they were younger, typically by about 8 years. They had lower ASA grades. So an ASA grade is kind of a measure of comorbidities. So they were less comorbid. They had higher pre-fracture functional status. And the key measure, I suppose, that we could make a greater impact on was that they received their surgery on time. So obviously, if we can get more patients to theatre, we can get more patients home. And that's something we can modify, and we should modify. I mentioned the growth of our orthogeriatric services already. So we're hoping by the end of 2019, every hospital that operates on hip fracture patients will have an orthogeriatric service. We've had some very good publications from the database as well, and we're currently working with a number of researchers on more research. But this paper in particular was published in the International Journal of Orthopaedic and Trauma Nursing. It was written by one of my physiotherapy colleagues, and for her master's she looked at predictors of early mobility in hip fracture patients. So she could identify which patients on admission should be fast-tracked home, who should be maybe for a longer rehab route, and vice versa. So in 2016, we introduced 2 new functional measures into the database, the cumulative ambulatory score, and the other score was the new mobility score. And I think they're also being collected in the Danish hip fracture register as well. So maybe we can do some work with that. But it's just given us that extra level of detail around the mobility, and we've heard a few times today how important mobility is for this group of patients. And again, this is just some more detail of the physiotherapy fields. Our key recommendations in 2017, we've kind of kept reiterating the same mantra that these patients should be treated as emergencies 7 days a week, okay? In some of our hospitals, the more small services, unfortunately, trauma is staffed Monday to Friday particularly well, and then on Saturday, Sunday, people don't break their hips, but of course they do. And we've obviously been working very hard to try and ensure that hip fracture patients, as well as trauma patients, should be able to get their surgery 7 days a week and have physiotherapy and have, all the services they need. So that's one of our kind of key recommendations: prompt access to surgery, and obviously having good governance locally. So there's no point in me telling all the hospitals, you need to improve your pressure ulcer incidence, you need to get people to theatre quicker. The hospital has to take ownership and act on it themselves. So I mentioned in 2018, we had been talking about maybe introducing a tariff into the Irish health system for a long time, and hip fractures was picked as the first up, best dressed kind of condition because we have a national database, we have good data, and we were very willing to try this. So We have our 6 clinical standards, and we also have 2 data quality standards, really, that they have to enter enough data on time and that they have to have their governance structures in place. So, what happened in 2018? Does the money make a difference? Well, it does actually. So we've seen our data quality go up. We're nearly at 100%, which is fantastic. Most of the data that we collect in the database is collected by nurses who are clinical and working on the wards and who do this as an extra to their job. So the fact that we're able to get almost 100% of the data through the goodwill of these nurses is phenomenal, and they're just absolutely excellent. You know, their support for the database is phenomenal. We've also seen a lot of the hospitals that hadn't got governance structures in place started to get themselves organised because they weren't going to get any money unless they had the governance in place. And then our 6 clinical standards. What you can see, standard 1 and 2 improved slightly. Our pressure ulcer incidence stayed the same at 3%. And then our last 3 standards, so geriatrician review, bone health assessment and falls assessment, have all had quite a dramatic improvement already. So we're very excited. That's just a summary of the improvement. So it's clear that an incentive, we were already improving slowly with the database anyway, but similar to what happened in the UK when the tariff got introduced, it just expedited that improvement a little bit further. So we're very happy that it's been a success because now other conditions will be considered for a tariff. These are some of my colleagues that work around the country collecting the hip fracture data. Most of them are orthopaedic nurses or emergency nurses or fracture liaison nurses. So I just want to give them all a big shout out and say they're absolutely fantastic. And if any